sure that people who have not had a chance to ask a question get the microphone once in their hands.
Thank you, Wanda. Appreciate it. Robert Miller from Reno, Nevada. I'm a patient. I just would like to ask Dr. Glazer, on your great talk on Epstein-Barr, from a patient perspective, I'm going to tell you that what came out of that and kept triggering within my mind was stress, stress, and stress. And so for people watching the webcast, particularly patients, just to kind of ask you to kind of revisit the virus part of that, that it's not stress coming and then virus, that you're talking about virus and then stress being added on top of that. Thank you.
Okay. EBV infects probably 99% of the North American population by the time we're adults. By the time we're 30, virtually everybody's infected with that virus. What's interesting is the virus was shown by Werner Henle, a very famous virologist and a terrific guy, and his wife, Brigitte Henle, that it causes infectious mononucleosis. Now, what's interesting about that is if you get infected with EBV, and in North America, in this environment, that's generally is in high school or college, and that's why it was called a kissing disease, because it spread that way. Only about 35 or 40% of people who get infected with that virus actually get clinical symptoms. Some can be very minor, like 2 or 3 days you're tired. Some can be very major, like I had it. I was out for 3 months. Okay? We don't know why that happens. Well, why doesn't everybody get infectious mono? More or less, in terms of clinical symptoms. We don't know. One possibility might be stress. The background going on in that person, when that person's infected with the virus, could impact on what that virus is going to do and to the degree it's going to do it. I don't know. I mean, I haven't seen any evidence for that. I don't think anybody's really looked at it. How do you predict who's going to get infected with EBV? It's not easy. But that could be one explanation, is that the stress immune dysregulation, particularly of cellular immunity, could impact on virus replication in the ways that we're looking at this, that could ultimately affect whether a person's going to have clinical symptoms or not. Don't know. But that's one example. But once you're infected with that virus, then you have it for life. And that means everything that goes on in your body, everything else that you're exposed to, in theory, could potentially interact with the endogenous virus.
Can I make a comment about stress for a moment? First, did anyone ever do that study? Actually, yes. The EBV stress, does that predict outcome study? That's Andrew Lloyd and the gang in Australia with the CDC that looked at acute EBV and Ross River virus and Q fever, and then wrote a paper a couple years ago after about 10 years of that study showing that the severity of the initial infection is what predicted who went on to have long-lasting, profound fatigue and symptoms 6 months post-acute infection. So it was interesting because I looked at stress.
That's not the same question. This is the question whether you get infectious mononucleosis tomorrow or next week rather than risk for something down the road.
That's very true.
So it's a very different question.
That's very interesting. But the other thing is people misunderstand what we mean by stress responses all the time, and I think that's really what you're asking. You know, the body has this amazing capacity to deal with stress. And we beat it down pretty good in this society, but it does manage. And there's a lot of complex interactions, not the least of which is your cortisol response to stress. What we know in chronic fatigue syndrome is that the stress response itself is very poor, and that data that we have from all our genomics absolutely underscores that the capacity, the connectedness of the endocrine stress response and the immune response is very dysregulated. And you have a very blunted capacity to make cortisol in response to stress. And it's a very important thing to do because it quiets inflammation. So there's actually been a lot of work on this over the years, and there's a lot of published papers on the stress response. And they're not talking about if you were just less stressed, you wouldn't be so sick. They're talking about stress response, a very physiologic thing that's not working very well. And when it doesn't, and you stress it, like on a bike for 8 minutes of exercise, I'm not talking emotional stress there, we're talking about physical stress, then we kick off all this inflammatory stuff downstream, and then a lot of other further things downstream of that. So, so be clear. It's almost poison to say the word stress out loud in this field, but it's a really important thing to say because, and unfortunately, it's like, you know, if we were Eskimos and we'd have 27 words for snow, we shouldn't be using the word stress all the time for for these different things. It's not. This is the physiologic stress response we're talking about.
Joan Grobstein, Philadelphia. I'm a doctor and a patient. My question is, we've had some discussion about the problem of contamination in the viral field, but we did not hear a discussion of the problem with contamination of the patient population, although we have heard concerns about that. Dr. Glaser made the point that perhaps we need to have a panel of physicians who deal with these patients, who certify them as bona fide chronic fatigue syndrome / ME patients. I think there may be a simpler way to do this, and I'm wondering why we don't do that, and that is to use the Canadian consensus definition. I don't think we have to reinvent the wheel. I don't think we have to spend as much money as would be needed to have a panel of physicians certifying patients. So I'd like to just hear comments about that.
Actually, there's a scientist in the room that actually did work on that. So Lenny, why don't you answer that question? What's your question? The Canadian case definition versus the one that we typically use. It's coming your way. That's really your question.
It's an excellent observation, and I think that we need considerable amount of more thought as to why that case definition is not being used by more researchers.
The point is, I think, you know, and also it's not, it's been done, these panels of experts reviewing cases. Actually, I worked with the CDC way back at the beginning of the time. I was on one of those panels with ADT and all that. Was it for the Wichita study? Oh, no, it was even before that. There's a study, even, it was the, gosh, that was a long time ago. I'm very old, and I'm going to say what year that was. But I'm older than I look. See this? This field makes you old. But anyway, it's a good idea to do panels. And we did the same thing with the Gulf War illness studies. We did panels of blinded, you know, physicians with blinded medical records. But if we're collecting enough data, we should be able to actually group people by symptom severity and symptom cluster, acute versus slow onset. There's a lot of ways to take the data sets we have, including using the Canadian case definition to lump symptoms, autonomic, inflammatory, endocrine, and then try to subgroup. And I know that when we did that, that work up in that, with the C-cubed, with the CDC, we had a huge amount of data like that. And we're able to group patients into basically, depending on the group you were working with, I think it was 8 subgroups of chronic fatigue syndrome that worked out when you had the physiologic, biologic, and clinical parameters. And then, I mean, it was interesting because doing that, you could pull out the menopausal woman. You could pull out these subgroups that were very small, but influencing the data set. It's totally doable.
Thank you very much. We have to reconvene at 1:15, and I want to make sure we've got enough time for this afternoon. I think some of the questions about patient selection or subject selection are going to reappear this afternoon when we hear those presentations. So lunch break until 1:15. Thank you.
Thank you for this. It's very
panel.
helpful. We've been trying to get our assays up and running.